Hello and welcome to the HIV Cure podcast. My name is Sakabo Sisala Marumo and I am back again with another episode. Today we're doing episode 4 and we're just looking at the role of antiretroviral therapy or ARVs when it comes to HIV cure research. We're going to dive more into it. We talked a little bit about it on episode 3. Now we're going to dive more into it, understand exactly how ARVs work and why they are not a cure, or how are they helping towards an HIV cure. And of course, I have another interesting and exciting guest. And this time around, it's quite exciting for me because I brought it a little bit, well, not a little bit, but it's home, you know. It's home, and I am super excited to have her here, to have someone from home, where I come from, finally. Hi, welcome to the HIV Cure podcast.
Well, thank you so much for inviting me.
Yes, so people are probably wondering, why is she so excited? Please introduce yourself. Let us in on what you do, the work you do, where you're from, and how you ended up doing the work that you're doing now.
Oh, okay. Well, my name is Dr. Ava Avalos. I'm an HIV specialist physician, and I've been working in Botswana on HIV soon for 25 years in October. So I've been involved, a very long time. So I've been involved in the HIV treatment program primarily since I got here so long ago, and have been involved in almost all aspects of HIV treatment and care over that time. I serve as a technical advisor for the Ministry of Health and have, again, really done a lot in improving the treatment program, I think. And I still see clinicians at Princess Marina Hospital when I have time. But I love patients, and Princess Marina is where I mainly see people. But I also travel a lot around the country to help with patients, and I lead the National Advanced HIV Care Team.
Oh, wow. So this is so amazing. So 25 years. So I guess you were there when Botswana first introduced antiretroviral therapy. I believe it was called the MASA program back then.
That's right.
Whoa. It's been a while. So I don't know but you know this, but I am an HIV advocate. I'm a young person who's openly living with HIV. So I started treatment in 2003 when it was still very new and we just didn't know. And I just knew that I had to take these because I started taking the syrup. I just knew that I had to take this syrup every single day. And then later on, I switched to tablets. And then, just the transition of everything it was, I don't know, because now I think I've been on treatment now for 22 years. A pro when it comes to talking about this topic of the role of ART when it comes to HIV cure.
Well, congratulations on doing so well. And I can tell you one of the wonderful things about being in Botswana is that there's so many of us that have really dedicated decades to making sure that people with HIV are living their best lives. So you're an example of that, and congratulations.
Thank you so much. And while we're still on that, can you just then explain to us what antiretroviral therapy is? How does it work? And just in the body, how does it work to help a person living with HIV? And also, why do people living with HIV have to take ARV for the rest of their lives?
Sure. Well, antiretroviral therapy is exactly what it is called, which is it prevents the virus, and the virus is a retrovirus, so that's kind of a unique thing to HIV. For those of you that have studied biology, the usual way that we think of proteins being created is you have a DNA transcript that sits in the nucleus of a cell, and it produces something called RNA. And the RNA is a script that produces proteins, and then the proteins go on to create all the different organs and functions across the body that are needed. And that's true in every single cell. And so that goes DNA, RNA, protein. but HIV is a retrovirus, so it infects the cell as an RNA virus, then goes to DNA, then implants itself in the cell nucleus. Now that's a lot of words, and if you had a picture, it would be much easier to understand, but I think those of you that have studied biology will be able to follow that. So that's why it says antiretrovirus, because that's what HIV is. So anti means it's been designed to stop the replication of HIV in cells that are infected. And over the years, even longer than 25 years now, they have been developing better and better antiretrovirals, so better drugs, to make sure that HIV is contained. And that's the difference between getting treatment versus being cured, because even though it can stop replication in the cells, if you take that medication away, the virus is unique in that it will immediately start to reproduce itself. There's some also cancers that's true of, right? Where now we're using immunotherapy and different kinds of modalities for cancer patients. So these medications, as long as you take them, are effective, and the virus or the cancers will go away. But the minute you stop medications, it finds itself again replicating. So that is why we definitely need to be able to find a cure, so people don't have to have that fear, and they actually can stop medications at some point.
Okay, and then when now it comes to having to take medication every single day, that you did say that people have to constantly be on antiretrovirals, then why then when someone is now undetectable, why do they still need to continue to take the antiretrovirals every single day, even though the virus or the viral load is very, very low and it's undetectable?
Okay. So undetectable is it's really a misnomer. And for a long time, we didn't use it because people think that when you say undetectable, that you can't find any virus in a person's body. But in fact, that's not true. If your viral load, so the viral load is what measures how much virus you have in your body. And different countries and different organizations have different quantities to say that someone is fully suppressed on antiretroviral medications, right? So some WHO says that you can consider a person suppressed if their viral load is less than 1,000. For many, many years in Botswana, we said we would consider somebody suppressed if it was less than 400. Or European countries and even the West say that suppression is under 50 copies. So currently in Botswana, if your viral load is less than 200 copies, we say you're suppressed, and that would mean you were quote unquote undetectable. But it just means that you can't find more virus than 400 cells per milliliter. And what does that mean? So if you think of maybe if you've had blood drawn before, and you look around the phlebotomy office and you can see these red top tubes, and maybe they're about 5 centimeters tall. They have red tops. If you divide that into 5, so a very small, maybe a cubic centimeter of blood, if your virus is less than 200, it means that you could find 199 viral particles in a cubic centimeter of blood. That's still a lot of virus. So although it's undetectable to the machinery that you're using to detect, still very much there, right? Now, it might not be enough to infect another person, but it is still enough to wreak havoc on the person who's infected. So if I don't make sense, you keep asking me questions, okay? So I can make sure that these words make perfect sense to a person who doesn't maybe have some experience in science. So when you have someone who's newly infected, the virus can be 1 million copies per cubic centimeter. So that person is just teeming with virus. People that are newly infected that aren't on antiretrovirals have so much virus in their blood that it's almost hard to comprehend how much virus there is, right? So the antiretrovirals will bring that down to something that's very low compared to what it originally was. It's still more virus than we want to have. And ideally, someone's viral load who's on antiretrovirals and stable is 0. And really, the 0 means undetectable, not 200, 400, or 1,000. HIV is a phenomenon. I always say there was a nurse many years ago that worked in the clinic, and she used to call HIV the devil with 1,000 faces because, and I always thought that was the best because it's a phenomenon. It's a virus that wants to exist. And that's one of the reasons why it's not even controlled with one drug, right? You have to have more than one drug. Now the drugs have gotten so powerful, so we can go down to 2 drugs. But, back in the day, we were giving people, 3, sometimes 4 drugs to control the virus because as it replicates, it makes mistakes, right? So in the body of let's say a skin cell it knows it's going to be a skin cell forever, right? And every time it produces what proteins are needed to create skin. But in this case, an HIV takes over, in this case, an immune cell, a CD4 cell, and basically says, you are no longer going to be an immune cell, you're now going to be an HIV cell. And because it doesn't have what they call high fidelity, the cell that it produces can have a different kind of DNA than the one before it. So it doesn't always reproduce perfectly. So we call that mutability. So it can mutate all the time, and it has been mutating, right? And there's a lot of us that just study the mutations, and that has a lot to do with really kind of also where cure research came too, of people looking at genetic mutations and genetic variability to figure out where is this virus really going. And we have to do that because, you can't tell whether someone is sick or not necessarily. You don't. It's difficult to talk about sexuality. There's all these different factors that together make HIV the devil with 1,000 faces.
Okay, I think I'm gonna start using that, the devil with 1,000 faces, and it and it makes sense. And also, you're talking about how antiretrovirals have advanced over the years, and even recently we've seen WHO speak of U equals to U, which is undetectable equals to untransmittable. So can you please just explain to us now how these advancement in treatment or advancement in ART has taken us to this U equals to U, or this undetectable untransmittable, and how exactly do these ARVs work to make it possible?
Okay, so undetectable equals untransmittable, or U equals U, is a really important advancement in HIV science because someone was able to say, what is the threshold of virus in a person's blood that is needed to say that that person would not infect another person if they had unprotected sex with them, right? Whether they're condomizing or whether they're not condomizing. And this is really important, obviously, because in people's intimate relationships, sometimes people disclose their HIV status, sometimes they don't, sometimes for many, many different reasons, right? People may not want to condomize. Just for pleasure alone. For some people, they feel that, they don't have a pleasurable experience. Another thing we've heard over the years is that as men get older, it's very difficult for them to maintain their erections when they're using condoms, right? And these were things we really didn't understand in the very beginning. We're beginning to understand, as time goes on, that condoms can be problematic for people. So if somebody now, because the research has been done, if somebody is stable on antiretrovirals, meaning their viral load is suppressed to less than 200 copies, it would be almost impossible for them to infect another person, even without condoms. Now, or especially without condoms, right? So that should be a motivation for everyone with HIV to make sure that they know what their viral load is. So to know whether or not they can participate in what we would consider possibly risky sexual behaviors, right? Like not using condoms. But again, has to be handled with care, because even though you can't get HIV, you can get hepatitis, you can get drug-resistant gonorrhea, you can get other STIs, right? If you're not using condoms.
Yes.
So condoms keep you safe from STIs. And so if you don't use them, yes, maybe you won't get HIV, but you may get a whole slew of other things that could be really dangerous for you. And you'd hate to die of resistant gonorrhea. It's not a pretty way to go, right? So there are many complications. However, if somebody is responsible and able to discuss sexuality and intimacy issues with their sexual partners, then you can know that information and be able to make decisions about your sexual behaviors that are the safest for you, right? And you can decide whether or not you feel like, for whatever reason, you're willing to take the risks involved in not condomizing. But the good news overall is that if an HIV positive patient is suppressed, the chances of transmitting HIV to their sexual partners with or without condoms is very low.
Yes. And also when it comes to just, reproduction, giving birth, as me, I'm a young person, I'm HIV positive, and then later on in life, I'm going to want to have children, babies, and also this is just how advanced these ARVs are, and this is now where U equals to U comes, that then in this sense, I can also protect my partner when we're not trying or when we're starting to have babies. Now, this is how this U equals to U comes in and plays a role. And then I also did mention earlier on that I've been on treatment since 2003. So this year is 22 years of me on treatment. And yes, I am undetectable, but now the question is, why can't these ARVs completely remove the virus from my body? Why can't I just be HIV free? Because I've been taking ARVs for a very long time.
Well, that's a really good question. And you're right I'm glad you mentioned the whole issue of when HIV positive people want to become pregnant, that U equals U is a real breakthrough for that situation. So thank you for mentioning that. As far as cure is concerned, or why can't the virus fully suppress and eradicate HIV, it has to do with something called latency. And what that means in this case is that the HIV virus goes into your blood system and it infects your immune cells. And some of those cells go back into immune tissue, into the lymph nodes or the spleen or any lymphatic tissue, and kind of hide there. They store themselves, right? So that they can continue to perpetuate themselves, right? Or when there's inflammation and they're being activated. So I know that kind of sounds like can sound a bit like gobbledygook, but bottom line is, well, doctors are so terrible. We have a language all our own, and sometimes I don't think we do such a good job in explaining. But essentially what that means is that there are tissues that store the HIV, and you can't, it would take, I think I once saw a modeling lecture that said it would take about 60 years of antiretroviral treatment to eliminate all of the HIV just from taking antiretrovirals orally, right? And that's because it just sits there latently. And so even though your virus is low in the blood system, there's still HIV virus hiding in your lymphatic system. And when it's activated, when it's stimulated for whatever reason, HIV will come back and grow, replicate. Did that make sense?
Yes, it did. And also on our previous episode, I think episode 2, we touched a bit also on latency. So our listeners can always go back and listen more on what we talked about on that particular topic. So
Oh, great.
it makes sense.
Oh, great.
And then also now I'm going to keep making reference to me so that it probably makes sense or people are able to better understand that I've been on treatment, on taking my ARVs for over 20 years, and we've seen that ARVs have been effective when it comes to controlling the HIV in my body. But why is it not able to cure the HIV? You touched a little bit about latency, and now we want to know that why can't we just drink ARVs and be cured?
Well, again, so ART is very powerful medicine, thank goodness, but you could never consume that much ARV and do well because there would be too many toxicities involved, right? The concentrations that you would have to have in the body are not sustainable for life, right? So these are very difficult. These tissues don't have necessarily great circulation. So that taking more medicine is not going to help the situation. It's a question of kind of over time bombarding that, the small amount that still exists. So unfortunately, oral medication, oral treatment is just not the answer for cure. Not something that is sustainable.
Uh-oh. Okay.
Sorry for that. Now, having said that, there are many, many medications that are coming down the pipeline. Those modeling studies were done some years back, and it could be with the new medications that are coming out, the long-term injectables, the lenacapavirs, maybe the need for treatment may go down to 20 years or 15 years or 10 years, right? So there's innovation that's taking place all over. We've had some big blows recently with the defunding of HIV research from the United States, but still Europe and many different countries are continuing to do really important research about cure and about figuring out how we can use antiretrovirals in combination with some of the cure remedies on the table to be able to show that HIV eradication is possible.
And just to our listeners, in case you're kind of like, oh, she's talking about lenacapavir, long-acting injectables, please don't worry. So the next episode, we're gonna touch more on that, on how lenacapavir or these long-acting injectables are working. What are the possibilities or when it comes to HIV vaccines from the knowledge that we're getting from these long-acting injectables that maybe now you can take every 6 months, and even the annual lenacapavir you take every year, you go for your injection. And also, how does that help when it comes to building knowledge and also working towards an HIV vaccine, which you know that currently we don't have that. So be on the lookout for that one. And then now coming back, Dr. Ava, now when we're talking about, you talked about latency, and now we want to know how do these ARVs interact with HIV reservoirs when now this virus is hiding, and how do the ARVs interact with them, and why can't they eliminate these HIV reservoirs?
So HIV as a virus, like other viruses, infect a cell. So this is the way I've been explaining it for 25 years. So you think of immune cells. So you've heard of hopefully your immune system, and your immune system is made up of very specialized cells that defend the body against what they call pathogens or any kind of disease or mold or fungus or bacteria that invade the body, either on the skin or, by inhaling them, getting in contact with any of these pathogens. And For the HIV virus, those immune cells are like chocolate. They love them. And they have special mechanisms to find where those immune cells are in your body. And they enter into the cell as an RNA virus. And then it's like a coup. They take over the replication of those immune cells, the replication function of those immune cells. And they just hijack the whole process. So instead of immune cell becoming an immune cell, it becomes an HIV producing cell. It's a coup, a complete coup, biologically, right? So the medications are designed to stop that coup at different places along the replication cycle, right? And they prevent HIV. Some of them prevent HIV from being an RNA virus to becoming a DNA virus. Some of those medications prevent that RNA virus from going into the nucleus of the cell and embedding the blueprint in the nucleus of the cell. Some of them prevent the proteins from being manufactured correctly. So essentially that whole process fizzles, right? But once an immune cell is infected and it goes, the immune cell itself with the virus DNA, and it goes into a latency period, the medications just cannot reach it, right? For again, your deep biologists can explain to you in more detail, but those viruses just stay there. So immune cells are really incredible cells in the body, because once you've had tonsillitis, right, the immune cells know it and they know how to fight it, and so they take that experience of an infection and they keep that history in latency. So the next time someone comes with a sore throat and breathes on you, those cells that have that memory and recognize, we've done this before, we have fought this virus before, we're going to come out and fight it again, right? But when you have an immune cell that is infected with a virus, the only thing it can do is come back and produce HIV. So suddenly that immune cell that's there in the immune tissues that should be fighting infections, the only thing it can do is come back out and create more HIV virus, right? So that's a huge dilemma, right? That's a huge dilemma that thousands of scientists have been working on for, some of them have been working on it for 35, 40 years, of how do you affect that? How do you affect that phenomenon of HIV, right? And there's many, I want to mention also that we have had some patients that have been cured of HIV, right? And I'm sure you've heard of those patients always presented at conferences, and there's probably about 4 of them now where these patients have needed bone marrow transplants, right? Where they completely eliminate the old infected immune system of a patient and then supply the patient with HIV cells that cannot be penetrated by HIV and are immune to HIV completely. And none of those patients have been reinfected. The problem, of course, is that to go through a bone marrow transplant is an ordeal. It's not an easy thing to do to scale, right? But what's important to cure researchers is that it was done somehow. So now the question is there some other way that can be achieved? Because we know if we can achieve it, HIV can be cured, at least in one way that HIV can be cured.
All right. Thank you so much for that explanation. Thank you for just clarifying, because a lot of us, there's still misconception when it comes to stem cell and how the other stem cells and how those guys got cured when it comes to through the use of stem transplant. mentioned on, I think, episode 2, and I talked about how on my TikToks, I get a lot of comments of people claiming that they're selling stem cells that people can buy from them and drink, and in the form of tablets or some medication that is not a stem cell. And yes, it's a whole procedure that is not scalable. That's why we don't have it in a lot of the countries, and it's a very expensive, non-scalable procedure that not a random person can just go and do a stem cell transplant.
Exactly. And it's also really difficult for patients. It is not an easy thing to go through. I have a number of people that I have known have gotten stem cell transplant for cancers, and it's an ordeal. So, it's not easy from a patient's point of view, and it's not easy from a medical infrastructure point of view either. But we've learned a lot from the cases that have come forward. We've learned a lot. So those were very brave people. They really are heroes that they've, allowed themselves to go through those procedures to see if there was any way that it would work. So in the end, it usually worked out really nice for them because they were cured.
Yes, and they sort of like took one for the team.
Exactly.
Yes, and we do appreciate them, yeah. And when we're talking about ARVs and how they work when it comes to being effective, when it comes to controlling the virus, and looking at the fact that now we have people who have been saved over the years who are still alive. Now, me being one of them, to say that I've been on treatment for the past 20 years, I'm still here, I'm active. It's normal life. I'm not different to any other person as long as I am still taking my ARVs, my medication. So then how did these ARVs or this ART, antiretroviral therapy, how did it help researchers when it comes to finding a cure for HIV?
Well, certainly, the fact that they were effective, the fact that there were compounds that were, originally AZT itself was an anti-cancer drug. It was chemotherapy, right? And they didn't know what to do when the first cases of HIV, surfaced. So they kind of threw the book at it. And it was this anti-cancer drug, AZT, that started to first see some effective treatment, and of course then all the other drugs came modeled on the molecular structure of what AZT was like back then. We've come a long, long way since then, and particularly in the effectiveness of preventing the virus from mutating. Right? So when you look at the second generation integrase inhibitors that prevents integration in HIV integration into the cell, things like dolutegravir that, almost everyone that has HIV in Botswana is on, or bictegravir, that's another integrase inhibitor, and there's newer integrase inhibitors, the cabotegravirs, the injectables. These medications have a very high level of replication of mutation. Right? So it's very difficult for patients to fail these medications. So those medications can take the virus really, really down low. And then scientists can study term effects. Again, how long do people stay suppressed? How long can you take off medication? What kind of cytokines appear in different processes in suppression, right? There's so many questions that can be answered in healthy HIV patients that have been suppressed, like yourself, for many, many years. The truth of the matter is, you're one of the people that is ideal to be able to ask questions about as far as elimination of HIV in the body. And luckily in Botswana, 97% of everybody that's on medication, this is unbelievable, 97% of them are suppressed, right? Botswana has one of the highest, if not the highest, suppression rates in the world, right? So patients, even though they've had to take medications every single day, they've done so incredibly well. And now they're looking at how do you even longer acting, as you mentioned, like lenacapavir, right? So right now they're looking at medications that you only have to take once a week, medications you only have to take once every 6 months, and maybe even longer, ones that will prevent patients from failing those medications. Now, what's important though is when you talk about things like long-term injectable medications, not everybody likes to get an injection.
Yeah.
So, really where the whole movement is going is being able to allow people choice, whether or not they want to take oral, if they prefer one pill every 6 months to one injection every 6 months, or one pill every week versus, one pill every day or once every 2 months. So there's all different combinations that are being tested right now. But the bottom line is to be able to give people a choice, because cure research is going to take a little while. I hope I'm wrong, but I don't think that our cure research is going to find a solution in the next couple of years. So in the meantime, we have to optimize treatment as much as we can to make it as convenient for HIV positive patients as possible, so that when the cure comes, their virus is so low that they will do very, very well with whatever kind of intervention the cure research comes up with, right? So no matter what you're doing, if you're HIV positive, you want your virus to be as low as possible, because then that makes you a better candidate for whatever new medications are going to be coming down the pike. So
Yes.
viral load suppression is the most important thing for now.
So for everyone, you must be going for or aiming to be undetectable, whether you are diagnosed today or you were diagnosed 10, 20 years ago. The main goal is for you to be undetectable and also just live a normal life. And now when we're talking about normal life, and you talked about choice when it comes to prevention and also treatment, please just share with us that when you started work in Botswana 25 years ago, when it comes to treatment-wise, how did it evolve over the years? How did it change? How did it improve? And also, how did it make life better for people when it comes to the dosing, the side effects, and as well as the delivery of these antiretrovirals?
Oh gosh, that's such a great thing. There's a wonderful diagram. Unfortunately, I can't show it to you, but I'm going to mail it to you so you can see, that has a picture of the evolution of antiretrovirals over the past really 30 years. And fundamental to that is that the medications are simpler to take. So we have one pill once a day. That's the most highly effective, better than those, there were times when people sometimes had to take 15 pills a day.
Yeah, I had to take like 10.
Yeah, I mean, you would get sick just from the capsules, let alone the medication, right? So now it's one pill once a day, so simple. The other thing is side effects. Many of us remember starting people on treatment and being afraid that they could die from anemia, right? And teaching people how to take their pulses and making sure that they had an adherence partner so that when they started medication and they had any of these problems, that somebody would be watching over them. All of that is gone now. We used to have horrible skin rashes that took place, like just horrible. Even doctors wouldn't want to look at the patients because it was just horrifying. All of that is gone now, right? So I think probably almost more than any other disease. I mean, there have been a lot of advances in cancer, but HIV has had more advances in treatment than many, many, many other diseases, if not all other diseases. And this is always an issue with the tuberculosis scientists, because they say, look at how much advances you've done with HIV, but you haven't done so many advances in tuberculosis, right? So now that tide is changing too, and what people have learned with drug development with HIV has really made a huge, huge difference across the entire healthcare system, right? So there has definitely been what we call optimization of those medications. So it's that you only have to take one pill. It's highly effective. It has a high very low side effect profile. And that's where we are right now. So that's just with oral everyday medication. So now we're looking at how do we make those medications last longer? So oral medications that last a week, oral medications that last 3 months, 6 months, and the like.
Okay. Yes, and like I shared a bit, like with me, I started with taking syrup twice a day, and it wasn't just one, it was like 3 other bottles, and then I went on to take tablets, and I used to take like 7 capsules twice a day, in the morning and in the evening. And then later on, that's when I started taking just 1 tablet in the morning and in the evening. And then now I am taking the 1 pill a day. So I have lived through the evolution of treatment.
Yes.
And
Congratulations.
thank you. And then I think that's why a lot of people, when we're talking about side effects, like back then, people on treatment had a lot of side effects. Like you talked about the rashes, like people could see that, oh, you're HIV positive. That's why it's even now, it's very difficult for people when I tell people that I'm HIV positive, they say that I'm lying. Or sometimes I do TikToks where I show them drinking my ARVs, and then like, no, that's PrEP. Stop lying to us. You're not HIV positive. Like people still associate HIV with having a certain look, that you need to look a certain way. And you can't just be a beautiful girl or a handsome man and you're HIV positive. Like there is no way. That's just how people don't believe that you are taking ARVs.
Yeah, I mean, it's miraculous. It's really miraculous what's happened with HIV. And, you're one of the people that can testify to that and help other people to understand how important it is to prevent it, to test for it, and then to take your medication until we have a cure, right? Until we do have the next breakthrough. And, we're hoping that that's, this very, very soon, right? And we have had, up until recently, the very best minds that were answering those very questions. So,
Yes.
just again, you think about cancer research. So now, if there's, certain cancers can be treated indefinitely, just like HIV. It's a miracle, right? People that would have died, within 3 years now, as long as they take their medication every day, they do extremely well. And then you're talking about, which I'm sure you have mentioned many, many times, about positive living, right? Making sure that you're eating well, that you're resting, that you're decreasing your stress, all the things that everybody needs to do those things.
Yeah.
But if you're taking antiretrovirals, it's as important as the medication at this point.
Yes. And then now we're about to close it off, and we're still now looking into the strategies that scientists are using. So what role does ART play when it comes to strategies like the shock and kill or the block and lock methods that scientists are using to try and cure HIV?
Well, I'm certainly not an expert at cure research, but I believe that really the role that antiretrovirals plays is to get the virus down to as low as possible. So when you're talking about shock and kill, where what they're doing is trying to make sure that the latent HIV in the body starts to replicate, the medication is there and puts a stop to it straight away. So shock and kill means you get all of those latent HIV cells out into the blood system so the antiretrovirals can kill it, or any adjunct therapy that they're using can kill the cells. Block and lock tries to suppress the virus, again, with strong suppressions, and not ever let those latent cells become so few and in so few tissues that it doesn't make a difference even if they did replicate. So both of them require, additional kinds of medications to shock the system, either by making the latent cells become active or making sure those latent cells are so few that they can't replicate later on. And antiretrovirals has to be a partner in that, because whichever way We need to keep any virus that is found within the blood system at zero. And I just want to encourage you again, don't think so much about undetectable as, below the level of detection. So people don't get confused as people say, oh, I'm undetectable. I don't have any virus in my system. That's not true. You will always have virus in your system until there's a cure.
Yes, and he did emphasize that people who are living with HIV need to be on treatment and shouldn't stop treatment even when they are undetectable, that we should be taking treatment until there is a global cure for everyone. And then now when we now look into these cure trials, how do researchers ensure that the cure trials involving these ARV interruptions are safe and are ethical for the participants?
Well, that's always with all, and that's why you have institutional review boards, which are ethics boards that look at the protocols, the things that doctors are saying or the researchers are saying they're going to do in the experiments. They look at them so carefully. They read every single line to make sure that whoever participates in studies understands the risks involved. Right? So when somebody asks you to participate in a study, even if they have a reputation for being the best, researcher in the world, the people that are signing on to those studies should ask as many questions about what are my risks, right? Like sometimes you might get a consent form that's 26 pages long and you have somebody saying, oh, sign this, it'll be good for you. But what HIV positive patients and really anyone that participates in health research should know is that you should be very clear you're putting yourself at risk for. So you understand what could go right and what could go wrong, right? Then you can make an informed decision.
Yeah.
And if something, hopefully not, but if something does go wrong, you're not caught off guard and you don't feel, you don't feel like it was something that you were tricked into signing on for. So always ask questions. In fact, ask your doctor questions. I can't tell you how many HIV patients don't ask questions, right? And instead, you listen to something on social media that could be completely false. But if you have a doctor there, you wait long enough in line to see a doctor, it's your time to ask questions. And sometimes people get scared when they come and see a doctor, but write them down on a piece of paper. And then the next time you have an appointment, ask the doctor to explain it to you. So service that you're doing right now for all HIV positive patients is so wonderful that you're trying to explain and get people educated. And I wish more all patients, but certainly people living with HIV were doing the same thing that you're doing. So congratulations.
Thank you so much. And also just thank you for making time to be a part of this, just explaining to people. And the whole point is just to explain in simple terms so that everyone is able to understand and also question or get answers to a lot of the questions that they have or that they have seen on social media. So that's the whole point of this podcast. Thank you so much for making time. And yes, to our listeners, please comment if you have any questions or just feedback. And of course, we will continue and bring you more amazing guests and scientists and people that you know from your communities. Until next time. Thank you so much, Doctor.